this scenario would be to ma'am, Dr. Shikha Goel. Will you give RT in this patient?
I would like to image this patient to see like what is contributing to this PSA.
But he has been imaged only 1 month back prior to surgery.
But we have seen patients who've developed a solitary bony met or has a new node in the paraortic region, and if we only give, even if we are tending towards RT, and conventionally RT would be given only at tumor bed and the conventional nodal draining basin, so we would completely miss those sites at a PSA of 10. If we
yes,
don't
ma'am. So
address
if we
those.
assume we don't see anything on we don't see anything, and we have this PSA of 10 and imaging is normal, would you give RT?
Yes, I would. I would not give only RT, but I would also want to add adjuvant ADT for at least 2 years for this patient.
Okay, thank you, ma'am. So I think we'll have to cut short our discussion for this case, and
Same patient, if he is not willing for surgery and he had a refractory retraction willing to the injury, what will you do?
so I think I will put this question to Ravi sir.
So in that scenario, sir, is not willing for surgery and retention, we would do TR channeling and put him for ADT and RT. That's what we do. So if retention, we have treatment, but for the patient for surgery, we will have to discuss the complications and decide. If he's not willing for surgery, do TR channeling and then put him on ADT and RT. Regarding salvage and correct me, I just wanted to bring up that point, salvage and adjuvant. We would give adjuvant, but if the PSA is less than 0.02, like for scenario 1, the entire idea of salvage is to detect it at an early stage and give it. So we keep the patient a follow-up. So it actually doesn't change anything. We know that this patient is going to fail at 6 months or 1 year down the line, and then we add it. But knowing that they would fail giving an adjuvant when the PSA is low, I honestly don't think it makes sense. So we can still wait till the PSA rises to 0.1. We can do an early salvage, which is 0.1, and then subject him for radiotherapy. Do you agree, ma'am?
Adequately counseled that the chances of failure are high, and then that they should report for follow-up regularly rather than be convinced that they will be okay in their lifetime.
All right. Yes, sir.
Can I make one comment?
Yes, sir. Sure.
About that TURB, what you have mentioned, channeling TURB. I think so. My personal experience is, I have read in literature also from Japan. We call it a cytoreductive prostatectomy. And bipolar TURP or bipolar TURP, I have found out that in lot of cases, only a percentage of the prostate may be having cancer, but not the whole gland. And I do like a conventional, I do a TURP up to the capsule. Try to do like that job. And I have good experience of some good number of cases where I have done, instead of radical prostatectomy, do a cytoreductive TURP followed by hormonal therapy or radiation therapy. And the outcome is very good.
And in the same go, I can say that I have patients, not one, few. You channeling TURP, they have already had radiotherapy, immunotherapy, or chemotherapy and everything. PSA is not rising. But within 3 months, they require another channel TURP. Then you don't know, they will give an extra radiotherapy, they say no. And then you do as much as possible, and 3 months later, another retention. So they are on SPC.
All right. Thank you very much, sir. So with this, I will conclude the ISU session. I would like to thank all the panel members. Thank you very much, sir and ma'am. Thank you.
Thank you, Dr. Gopal. I know I was standing on your head trying to ask you to finish the program. There is a slight change there because of some logistic reasons. Professor Anish debate is preponed at the next talk. So I will request Professor Anish sir. Anish sir, please sir, please. So the debate will be done first, and because sir has to board a flight from Chandigarh. So we will carry on with the rest of the programs later on. Thank you.
Good afternoon. So actually the entire team has to leave. So we'll have now another interesting debate on the upper tract urothelial carcinoma, the UTUCs. And as we have all been traditionally taught that it is the radical surgery or the nephrouretrectomy which had been the mainstay of treatment. But with the evolution and things changing with time, we have now the conservative or the nephron sparing things into the vogue. So I have the experts in this area, Dr. Uday Pratap, who is from SCPGI, and then Dr. Nayak from AIMS, Dr. Himanshu from TMH Varanasi, and Dr. Neeraj Goyal from Chandigarh. So let us begin with Dr. Uday Pratap. Can you come forward and present your case? Thank you.
By the time Uday reaches the dais, there is a small announcement for all the faculty members that the mementos have been kept at the registration counter. Please be kind to collect it from there. Thank you.
Good afternoon, everyone. So I am going to present actually in favor of kidney sparing in the upper tract urothelial carcinoma. So before going into the detail, we should know what is the current status, what we are doing actually to preserve the kidney. If you look into the data, you can see in this article around 12,000, more than 12,000 patients, they had a low grade biopsy, and only 20% patients they actually got the endoscopic treatment done. Rest of the patients they underwent some kind of surgery, radical nephrectomy, and other kind of surgery. Parallel to this article, if you see, this is the outcome of radical nephrectomy, and if you analyze this data, the specimen of the nephrectomy specimen, then you can find around 21% patient they had the TA disease, and around more than 1/3 patient they had the low-grade disease. So I am not saying that we should do endoscopic management for all low-grade tumors, but still there is a lot of hope of improvement. So my colleague, Dr. Himanshu, know only the one treatment for the upper tract urothelial carcinoma, whether it's a low-grade, low stage, and whether it's a small or big. He just want to knock out the kidney. So do we really need to run down the house? So I'm going to present some rationale why we should go for the preservation of the kidney. Number one, if you see, if you go for the nephrectomy, that has an operative risk. So if you go through this article, around 40% of patients they can have a minor complication, and around 8 to 10% patients they can have a major complication, because this population actually have a lot of comorbidities, older age groups. Second rationale is that because these patients have a already a lot of comorbidities, so they have a already baseline GFR is low. So when you get the one kidney out, so further it's going to get the CKD state worsen. So they can have a later on sequelae of the CKD like cardiovascular morbidity or mortality. Third one is that if you see the solitary renal models, so radical nephrectomy followed by the dialysis, and if the patient goes for the endoscopic management, even in the worst case scenario, if we got the recurrence at every visit, still that is have a whole less lot, the cost is lot less as compared to the radical nephrectomy. And number 4 is that you can see that compared to the previous decades, now we have got a lot of improvement in the optics of the flexible ureteroscopes and the lasers. So even the flexible ureteroscopes, they have a NVI inbuilt, so we can pick more, we can see more in a better way, we can ablate these tumors in a better way. And the fifth one is that if you see the outcome, so if you compare the endoscopic management with the radical nephrectomy, so cancer-specific survival is the similar, but improved renal function outcome. Although these patients, there are no randomized trial, and these endoscopic patients, they were carefully selected. So, how to select the appropriate patient based on the risk stratification? If you go through the risk stratification, it depends on the biopsy grade, cytology, imaging, appearance on endoscopy, and whether this patient had lower tract involvement or not. So we can divide into the low risk group, high risk groups. Further, this group divide into the favorable and unfavorable, and the treatment depends on the risk stratification. So low risk group, basically you can offer the ablative treatment. And in high risk group, some patient you can offer the ablative endoscopic treatment. If go through the guideline, in EU guideline, if you see, for low risk group, you should offer the kidney sparing management, and in high risk group, in some patient you can offer the endoscopic management. So I am just going through some clinical scenarios. So this patient presented with the upper tract urothelial carcinoma, and we got the CT scan done. So he is having a 1.5 centimeter lower calyceal growth, and biopsy was low grade, and other things were the normal. So this patient falls into the low risk group and favorable. So you can treat this patient with the endoscopic tumor ablation or chemoablation. So you can have a laser, you can use holmium laser, you can use thulium laser. The thulium is slightly better than the holmium in achieving the hemostasis. And then you can, if you want to put some kind of adjuvant therapy, so you can put a stent, and then you can put the adjuvant therapy also. So this is the retrograde approach to ablate these tumors. And this is a case, 83-year-old male who got the radical nephrectomy done, and the radical cystectomy with ileal conduit done for right upper tract urothelial carcinoma and the muscle invasive bladder cancer. Now he presented with the gross hematuria, and you can see the GFR is 22, but other things were excellent, functional status is excellent. So patient declined to undergo radical nephrectomy with dialysis. So because the GFR is low, you cannot give systemic therapy, and biopsy was high grade. So in this patient, if you go through risk stratification, this patient falls into the high risk group actually. So this patient was treated with the percutaneous endoscopic management. So you can use the resectoscope to resect these tumor. You can simple bipolar resectoscope, or then you can put a PCN tube, and then you can give the adjuvant kind of therapy later on. And this patient presented with the right lower ureteric tumor and the bladder tumor. So you can see I have resected the orifice, and there was a tumor in the lower ureter, and the rest of the ureter and the kidney were normal actually. So you can do the segmental uretrectomy. So these patients are doing good. And one more thing is that chemoablation. So this is came from the Olympus trial. There is a gel mito, which is the actually mitomycin containing liquid fluid. When you put through the RGP, this ureteric catheter into the kidney, it's become the gel actually. So it basically exposes the tumor tissue for the mitomycin, and you can see the result of this Olympus trial. So you can find the complete response rate was around 60% actually. On 80% of responses were durable at 12 months. So conclusion is that radical nephrectomy is significant risk factor for development of CKD. So endoscopic management may offer similar oncological benefit as radical nephrectomy. It preserves the renal function, prevents the long-term complication associated with CKD, and avoids surgical morbidity. Thank you.
So, Uday, what is the incidence of seedling after percutaneous management?
Sir, there is no robust data. Some cases are there, but not much actually. So, yeah.
Okay, so may I ask now Dr. Himanshu? I think he is going to present the opposing views here. Himanshu, please.
So a very good afternoon to all. And at the outset, I would like to thank NOZone and organizing committee and Anish sir to give me the opportunity to speak on this topic. I would be talking against renal salvage. So before starting, हम जब MBBS में घुसे तो रैगिंग होती थी सर, अभी बंद हो गई. तो उस टाइम हमें सिखाया गया बॉस इज ऑलवेज राइट. Unfortunately, this time boss is not always right. So the boss is not always right. तो मैं चालू करता हूँ. So my disclosure is I would like to acknowledge my fellow colleagues Dr. Shashank Sani and Dr. Ankit Joshi who helped me preparing this debate. So as we have seen that there is a risk stratification for the upper tract urothelial carcinoma, low risk and high risk. So categorization has already been told by Dr. Uday Pratap. So high risk UTUC comprises of hydronephrosis, tumor size of 2 or more than 2 cm, with a high grade cytology, high grade URS biopsy with multifocality, previous radical cystectomy for high grade bladder cancer, and variant histology. And if we go for the treatment, surgical treatment, as per the risk stratification, you can see that organ sparing or the kidney sparing surgery is indicated only for the low grade tumor and in only selected high risk tumors. And I have borrowed this slide from Dr. Uday Pratap himself. You can see only 20% of the cases are TA. Rest of others are either carcinoma in situ or T1, T2, T3. And around 64% are high grade tumors and around 29% are with carcinoma in situ. So majority of the patients they present to us, they are high grade and high stage. Unfortunately, Dr. Uday Pratap Singh boss बोले हैं, तो वो जो ट्यूमर्स हैं उसको फूल दे के ट्रीट करना चाहते हैं राज की तरह सिमरन को. But he doesn't know that actually we are majority of the times we are dealing with Mogambo. So as European Association of Urology has also and as well as the NCCN has streamlined the treatment that radical nephrectomy with template lymphadenectomy is the gold standard for the high risk as well as for the low risk cases. So if we come to the nephron sparing surgery, what are the disadvantages? Dr. Uday has delineated advantages. I would delineate the disadvantages, that there is a sure risk of tumor seedling after percutaneous management, and there is a potential risk of understaging and undergrading of the tumors. So all these data are from the recent European Association paper. So if we go by the guidelines, segmental ureteric resection is recommended only for the low risk tumor. That is not the majority of the cases. And to add on, the segmental resection of the mid and upper tumor is associated with a high failure rates than for the distal ureter. And it is worthy to mention that partial pylectomy or partial nephrectomy is extremely rarely indicated for UTUC. As Dr. Uday has talked about the topical installation, I would like to highlight that there is insufficient evidence for current EAU guidelines to make it a recommended treatment, and there are controversial areas regarding its modality of administration and its clinical effectiveness. Again, it carries, antegrade perfusion carries the potential risk of tumor seeding, that is the real chance, and retrograde installation is associated with high risk of ureteric obstruction and pyelovenous reflux. And if we go for the treatment or the chemoablation with putting a DJ stent relying on the VUR, the main problem is that the reflux is not guaranteed and may or may not, it may miss, there are certain real possibility of missing the calyces that actually we are leading to under-treatment of the disease. So if we talk about the recurrence, there are 2 to 6% chances of recurrence in the contralateral upper tract, and after going for a kidney sparing surgery, careful follow-up is highly required because of the high risk of disease recurrence. And despite the improvement in the technologies and the equipments, stringent follow-up after kidney sparing management is difficult because the repeated endoscopic procedures are frequently necessary. So this was a paper which highlighted the challenges of conservative management in UTUC, highlighting the requirement of advanced endoscopic skills, expensive equipments, and the most importantly, compliant patients who are willing to undergo multiple procedures. And it was highlighted that in ESRD or CKD patient, particularly the high-grade tumors in the form of UTUC develop and they ultimately fare worse. They concluded that real-world costs are difficult to calculate, especially when you include loss of productivity, morbidity, etc. So the cost analysis they conducted was very conservative. Mind it was very conservative, and it underestimated the real cost of preserving a kidney in the setting of upper tract urothelial carcinoma. So this was a paper which actually studied the impact of nephron-sparing surgery on survival in upper urinary tract urothelial carcinoma patients when it was stratified by tumor characteristics, means low grade and high grade and favorable, unfavorable. So they concluded that their research has several limitations. Firstly, that CR database was a retrospective, that is the main disadvantage. We have all the data who are collected from the retrospective analysis. Secondly, the patient's physical condition was unclear. Patients with much complications, they might pursue more conservative treatment, which resulted in the bias, selection bias. So additionally, regarding the chemotherapy and radiotherapy, nothing was very much clear. This was a paper published in Indian Journal of Urology on the long-term follow-up of outcomes of percutaneous nephron-sparing surgery for UTUC. So they highlighted the requirement of the highly skilled surgeon not for the TURBT only, for the PCNL procedures. And the nephron sparing surgery, it requires a very careful patient selection. So only small solitary tumors in the renal pelvis or the lower pole calyx can be treated. And last but not the least, psychologically it is very important to counsel the patient that clinically suitable patient should be included and must agree to intensive follow-up regime. Then this original research article, which again evaluated the kidney sparing management versus nephrorectomy. This was a systematic review and meta-analysis which concluded that there is no compelling evidence that kidney preservation procedure provide equivalent tumor. Why? They concluded that equivalent effect most probably was due to low grade and low stage upper tract carcinoma, the paucity of the number of the patients included in the data, and most importantly, the low quality of included studies and selection biases. Although they concluded that multivariate analysis was conducted, despite that they found that the quality of the studies were low. So they said that the results should be interpreted with caution, and the kidney preservation management as of now should be conservatively applied in low grade upper tract tumors. Additionally, they highlighted that it is required that multi-institutional randomized trials are needed for further verification of the present retrospective data. This was a systematic review and meta-analysis by the EAU non-muscle invasive bladder cancer guideline panel, and what they found that 22 studies which were eligible for this meta-analysis, all of them were non-randomized and comparative retrospective studies. So they found that only patients with low-grade and non-invasive tumors, they experienced similar cancer-specific survival after conservative renal sparing surgery when compared to the radical nephrectomy. When the risk of bias was assessed, it revealed that analysis was subject to a severe selection bias favoring the KSS, obviously because of the mostly inclusion of the low-grade tumors. So they concluded that because of the selection bias, results should be interpreted with caution. Finally, in the recent paper in BMC Urology 2023, so it was said that for selected patient with high risk urothelial carcinoma, the efficacy and safety were satisfactory, but they emphasized that we still need to conduct prospective or randomized study to validate the value of segmental uretrectomy in patient with the high risk urothelial carcinoma. Then this was again a meta-analysis and systematic review in European Journal of Surgical Oncology, where it was conclusion was drawn that the low level of evidence and the heterogeneity of the studies limited the quality of the results, and in the absence of prospective and randomized studies, the equivalent oncological controls of endoscopic nephron sparing surgery or RNU is not provided by this meta-analysis. Further, they emphasized the multicentric prospective studies are urgently needed to assess the oncological outcomes of UTUC with endoscopic management. And in the next multicentric study, the patient should be matched on the basis of tumor stage and grade at diagnosis. So, as I said that there are high recurrence rate after endoscopic approaches in the upper tract, around 65%, and in the bladder 40 to 50%. So, second surgery, after the endoscopic surgery, there are real risk of missing tumor. It was detected that around 51% chances were there to find out the residual tumor at second look URS, and repeated URS is associated with risk of strictures. There is a definite need of adjuvant treatment after kidney sparing surgery. In 30 to 70% of the patient, they experience local recurrence following endoscopic management, and adjuvant topical therapy is required, and that is still not standardized. So as far as the CKD development is concerned, this is a recently published article in February 2023, where it was concluded from Duke University, where it was found that multiple comorbidities to be associated with incidence of advanced CKD, including age, diabetes, and recurrent AKI. So they concluded that nephron sparing surgery in UTUC may provide a renal function benefit to some, but not to all, especially those with the medical factors at baseline contributing to CKD, because the patient is already biased, selection is biased. So what are the advantages of the radical nephrectomy? This complete tumor removal, low local recurrence rates, simplicity to follow up the patient, especially in our Indian scenario where patients are coming and they are lost to follow up after hematuria to khatam ho gaya, doctor sahab peshab mein khoon aata nahi, ab kya karna hai. So appropriate for high stage tumors, rather this is the most appropriate for the high stage tumors. Long term oncological outcomes are very good in terms of overall survival rate, time tested. So to conclude, when solving the problems, we should dig at the roots instead of just hacking at the leaves. Ultimately तो राज को भी बंदूक उठानी पड़ी थी सिमरन को ले जाने के लिए. So इससे बेहतर तो हमारे टर्मिनेटर ही हैं. भगवान राम को भी सीता को ले जाने के लिए रावण को जो मार रहे थे तो सिर काट रहे थे रावण के, तो रावण का सिर वापस आ जाता था. सो नाभि में ही अमृत जो कलश था उसको मार के तीर एक